Okay, now we'd like to call up Dr. Julio Pow-Song to speak about data synthesis to support best practice statements in focal therapy.
Thank you, Dr. Watts. It's a pleasure to be here. My task is very simple because I have to address data synthesis to support practice statements. So a take-home message is that there are none. These are my disclosures. So best practices for focal therapy, why does it matter? We know that increasingly patients are seeking this therapy. There are more practitioners performing this type of procedure, but none of the guidelines, and I'm going to review that, give any support in giving guidance in how to best practice the application of focal therapy, from patient selection, how we evaluate the patients, the treatment, and how we follow them up. It's an evolving field, and that's a challenge. It's constantly changing, and there are multiple technologies that are available. So if you take all the non-guideline entities, none provide actual statements regarding how to best practice the craft of focal therapy. But it's here. And as you heard in the previous session, many of the devices have been cleared, and one has a specific clearance actually for cancer. So the guideline panels are very picky in looking at how they take a technology or a procedure and approve it. And then after that, they set up the process regarding patient evaluation, selection of patients, how the procedure should be done. But at the end, it's expert opinion, it's a consensus, and then all have to agree about doing this. And many of the entities, as you know, have not gotten even to that point, unless providing guidance on how to best perform the procedure in their different aspects. The NCCN guidelines have categories of evidence and consensus, but nowhere in the guidelines it mentions the use of focal therapy and only makes a very generic statement that it could be used as an alternative for failure after radiation therapy. The European Association of Urology, with other 5 entities, also provides some very generic statements, and the highlight said that is less toxic, prospective trials are needed, that it should be performed in the context of a prospective registry, if we're talking about HIFU and cryotherapy, at least in Europe, and that it should have prospective clinical trials if we're talking about other technologies. The National Institute for Health and Care Excellence in the UK gives a special arrangement to perform these procedures so the government can reimburse it. And it has a process in which the hospitals, the physicians, and the patients have to go through a workflow in order to approve the procedure, to do the procedure. And this is specifically for HIFU, the recommendation that came last year. And there's one for IRE and cryosurgery from previous years. And they took some of the reports, one from the European Association of Urology, which was in 2018. And that nowadays is like a century because things are changing so fast. There was another report from the German group, which also gave a generic recommendation that there wasn't enough evidence to support focal therapy as a standard option for the treatment of cancer, of prostate cancer. The University of California, knowing that there were no guides, the whole system, the 5 universities got together, conferred with the urologists in their area of influence, and came up with consensus statements. So at least there was an attempt to provide best practices as is related to patient selection, basically using the NCCN guidelines in the favorable intermediate risk space. how patients should be evaluated regarding adequate pathology, grade group 2 and 3, imaging requiring MRI, fusion biopsy, and then a follow-up protocol, how often to do a PSA, MRIs, and indication for rebiopsy. And this is really one of the few organizations that have come together in a big state to give a recommendation of what to do. And all this stems because most of the guideline entities take level of evidence. And if there's no one level 1 evidence, which is basically a prospective, randomized clinical trial, or a meta-analysis of randomized clinical trials, it's not going to pan it out. So the level of evidence in general is indicated of being of low or very low range. And Dr. Polasik actually did an editorial based on this report, acknowledging that there was lack of level 1 evidence, that there are multiple technologies to assess, the issue of access. Not many places have access to this technology, not only worldwide, but even in places here in the US. The economics, the expense, the reimbursement, so no way to assess for clinical efficacy when comparing to other treatments. And there was a call you heard about having a registry, a solid registry, and it's amazing how this number had increased so much in the last couple of meetings, and it's getting closer to the HEAT registry in the UK and other registries in other parts of the world. So because of that lack, Dr. Polasik also mentioned that as a society, then the group comes together and tries to develop a consensus based on what is available in the literature. Lack of high-level evidence is not an indication of lack of evidence at all. So you take what you have and come with the best possible statements to help the practitioners practice focal therapy appropriately. So there were guidelines regarding selection of patients, how do you follow these patients, on what the terminology for focal therapy is, and an agreement as knowledge and technology development develops on how to treat the patients more appropriately. And we're not talking about what you see at the top, which is just treating the lesion, but more doing like a quarter gland at least, or a hemigland, to be sure that one provides appropriate treatment. Also a recommendation of how to follow up. And more recently, Dr. Rodriguez-Sanchez did a focal therapy consensus, the FALCON, and did a survey worldwide from practitioners involving urologists, radiologists, radiation oncologists who perform any type of focal therapy, and came up with recommendations for best practices regarding patient selection, taking clinical, pathological, and radiological features, the treatment approach with the extent of the treatment, to be familiar with the energy that one is going to use, and the extension of the margins. And then the adequate follow-up, so there's standardization of follow-up of patients, and also as a quality assurance, because it includes the recommendation to do a biopsy at one point after the treatment as a QA. And it's interesting to mention that probably there wouldn't be a randomized prospective trial with an invasive procedure versus a less invasive procedure. And this is the Imperial Kronos study that did a pilot randomized clinical trial in two groups, one randomizing focal therapy with radical intervention, either surgery or radiation therapy, and the other one using neoadjuvant therapy or not with focal therapy. And I think 7 institutions came together, and it was a tough study because it was during the COVID a couple of years, but they ended the study and came up with an interesting finding. And I think we've seen that before, that doing a randomized trial when there's a radical intervention, that's impossible to achieve. in this small group, which was very closely followed up. Patients were very well advised. Only 22% of the patients, almost one quarter, withdraw from the trial, not wanting to have a radical treatment. And very few with the focal withdrew when they were randomized to the focal therapy. The other component of the study was using an adjuvant treatment to focal therapy, and in this case, they use a treatment for 3 months with finasteride, I think, bicalutamide, and other finasteride, and they proved that that study could be done, randomizing patients from neoadjuvant, whatever kind of treatment that might be. So they conclude that it would be very unlikely to perform a randomized trial between focal therapy and a radical treatment, but it is possible to create newer trials, and you heard this morning that there are some initiatives to include some type of adjuvant treatment to focal therapy, i.e. immunotherapy. So in conclusion, there is no much level 1 evidence that can, at least from the guideline entities, to provide best practices. Nevertheless, there are many phase 2 trials that are coming out with the different focal therapy technologies that are going to help out provide some guidance regarding best practices. It's important to have high-quality registries, and I would encourage everyone to go into a registry. We recently are going through the process, and it's very easy to do. There's a lot of support. Eventually, there will be partial guidance from entities, probably mostly coming from Europe, either the European Association of the Urology or the NICE, or NICE, how is it called? Well, thank you very much.